everybody, and welcome or welcome back to an Invisible and Invisible Illness Awareness Project. This week we're getting into Emerge Australia's second speaker at the International Research Symposium for ME 2019. His name is Dr. Wauchope from the Bedford Medical Clinic in Adelaide. At the talks themselves, they had somebody come on stage and introduce the speakers and give their background. I did cut that part out just to get straight to the point, and Dr. Wauchope has sort of a preface to his speech that I probably would have cut out too, but that really made an impression upon me because he was basically referencing what Dr. Donahue said and really emphasizing how important that is. And that really stuck out to me because I was thinking, wow, first of all, he's really actively listening to what this other doctor is saying, and I don't know, if they really know each other that well or work together, but he's just trying to drive the point home that this is something very urgent, that people need to pay attention to this. So if anybody missed that in the midst of Dr. Donahue's entire speech, he made sure to emphasize that. And a lot of times in his speech, when he's referencing something that Dr. Donahue also said or giving a similar metaphor, he makes sure to acknowledge the fact that Dr. Donahue said something similar. So I really did like that. It's not like he was just in his own bubble. A metaphor that Dr. Wauchope himself had was that it's kind of like you have a typewriter and each key on the typewriter is a diagnosis, but what do you do when your diagnosis is not one of those keys? Which is of course something that people are going through now with ME and something that a lot of people have gone through in the past with other illnesses when they were first sort of being discovered and researched. But another thing that came to mind was that in order to confirm an MCAS diagnosis, you have to do the labs during a reaction because a lot of times you're not going to get those elevated levels you need just on a normal day. So there were several times where I was in the ER and I just kept trying to get them to run a 24-hour urine analysis, and they're like, well, we can take your urine, but we don't really know what to do with it because that's not in the computer, and we have to be able to select one of those options. So basically, I don't know, this cup of urine was just sitting around and got lost, I guess, which is, kind of like the smaller scale version of what's going on with this. Yeah, Amy is the cup of urine. He says ME is an umbrella term for different pathologies that present in the same way, which, again, always great to emphasize this. It hasn't been subgrouped, but it needs to be, otherwise any clinical trial will be non-conclusive, because obviously if it's different pathologies and they're all presenting in similar ways, but they have different origins, then you're going to need a different treatment for each of them. And even any labs you do are not going to conclusively tell you what the cause is because you've got all these subgroups together and they're all coming from different places. He said there have been doctors who haven't been able to find infections, but then when it came to a few different children who were sick, they were prescribed corticosteroids, and the steroids downregulated their immune systems, reduced inflammation, and then it turned out that they actually did have an infection that was just undetected and was then, through the corticosteroids, allowed to run rampant, and these children ended up dying. So clearly there are pathogens that we don't know about and don't know how to test for yet, and that is definitely something that I've also thought in my whole journey to all these specialists trying to find an answer, was that if I'm coming to you with symptoms and you run all of your tests and you don't find anything, then obviously the tests are just not where they need to be to find the problem. But if there was no problem, I wouldn't be here. People perceive that as psychosomatic before the test is developed, but then after the fact it's like, oh yeah, now we have the test to prove it, so it was valid all along. But what about all the people who came in before those tests were developed? that just because you didn't have the test to confirm it doesn't invalidate the reality that it existed. And that's exactly what we're going through now, and we will continue going through until the tests evolve to where they need to be. And on that note, another thing that he emphasized that I really loved was the need for future doctors in this specialty. This is something that I believe Dr. Theoharides, the MCAS specialist, mentioned in a seminar that I watched a couple years ago, which is that these doctors are kind of getting up there, and once they're gone, either retired or just really gone, we're not gonna have people with that knowledge anymore. So they need younger doctors that they can train now to continue on and develop this research into the future. And honestly, I think that was probably the moment that kind of sparked this desire in me to maybe consider studying medicine if I get to the point in my health where I could manage that. That's not the path I was originally going down, but I've learned so much since I've been sick, and I kind of think, hey, maybe if I can get to a point where this is manageable, I should try to pursue this so that I can be that specialist, because then I can be someone empathetic with first-hand experience who can help others. So if you're watching this and you're in the medical field or planning to get into it, definitely consider the need for specialists for these either rare or under-researched, underfunded diseases. And last thing I want to say is, just to be clear, I'm not doing bullet point summary of the entire talk. I'm just telling you what really stuck out to me, that I had something to comment on. All of these speeches are getting really in depth into certain biomarkers and different treatment options that they've tried, and I just chose not to comment on those because I don't really have anything to say about them. These are things that I haven't really tried, but don't think just because I'm not mentioning it that the speeches don't go in depth on that stuff. There's definitely a lot of great information that I would recommend you guys check out. If you don't want to actually watch the whole speech, one good thing you can do is just sort of fast forward to where you can look at the slides and read the notes. And if you see something that piques your interest, then just stop and listen to that segment. So yeah, without further ado, here's part 2, and I will see you guys next week.
Dr. Wauchope.
Sorry.
It's all right. It's Scottish. It lends itself to mispronunciation. So,
Judge anything by my pronunciation.
yeah. Look, I'd like to start by thanking the government for the money to bring Ron Davis et al. And all the others here and get this going. It is a phenomenal thing that if you look at the scientific stuff that's been revealed here this week, for doctors who are working in this area who get told it's all psychiatric, it's all psychological, and that's still out there, we can refer to something that our federal government's funded, that's here, that has world-class people presenting, that is up there and is a beginning. So I think for a lot of you in the room, you wouldn't appreciate that, but if you've heard what Mark Donoghue said about the pressures coming on doctors who don't fit the keys. See, the way medicine works is we have like a typewriter, right? So I have a symptom complex. I have a bunch of symptoms, and that is then classified as a diagnosis, and that diagnosis equals a drug. So symptom complex goes straight through to drug. But what do you do when the symptom complex doesn't equal a key on the keypad? Where do you start? And what the medical board's doing is saying, we've already got this thing worked out. Symptom complex equals diagnosis equals drug. You're outside. You're actually dropping into the cracks on the keyboard. Now, the problem they've got is there's wacky people out there. There's people banging fish over people to transmit life, and there's there's a weirdness going on, which when you go and talk about and present lends itself to criticism, which means people trying to help people with undiagnosable, unmanageable, unclassifiable illnesses are left vulnerable. So one of the things Emerge could do would be back up what Mark's doing, and if the chronic fatigue people can make submissions to the Medical Board of Australia and really go for it, that would really help the people working in the area. What Mark's put down is an ultimatum. He said there is a time in April when doctors are going to be in trouble. Did you hear that? So please, if you can do that, that'd be great. One of the other things, and I'd like to thank Emerge for organising this conference because it's phenomenal, they've got people together, is if they could make a submission to the Royal Australian College of General Practitioners. There is still on our website malpractice. They are still recommending graded exercise therapy for people with chronic fatigue. And we all know, and you can prove it biochemically, it makes them worse. That paper was fraudulent, and it's on record, so that was a fraudulent paper because they changed the entry criteria and the outcome criteria. Yes, the PACE study is fraudulent because the entrance criteria rated you here, and when you went out, if you were the same, you were successful. They changed and they've refused to respond to clinicians and researchers from around the world for the fundamentals of that research and open it. It's all been hidden. There was a conflict of interest. The people doing the paper ran a business for pacing. So there's a financial imperative for that paper to get out, help their business. It's hurting people around the world. It needs to be taken off the RACG website. So if Emerge as a Victorian thing could get onto the Victorian RACGP and give them a pat on the head, we'd all be happy with that. But please follow up what Mark said. From wherever you are, push for the Medical Board of Australia. We don't want cranks. We're not justifying cranks, but there's biochemical doctors trying to help ill people who should be protected. Okay, and I'd like to thank Ron Davis for what he's done in pulling together people from around the world. If you look at what they've done in progressing this illness, they've thrown research at things and come up with nothing, thrown research at things and come up with nothing. If it had been government-led, it would have stopped. How many negatives do you go before you stop? I want to thank you to some other researchers we've got in metabolomics here in Melbourne and others who have kept going. There's people who have kept going, and now what we need is we need people to pull this together. So I'll whiz through this quickly. Where's my clicker? That one here? Okay. What you're going to see is part of an integrated program we've developed with Bridges and Pathways. What we're aiming at is a client-focused, nurse-led, diagnostic treatment pathway using a layered, targeted problem-solving approach that's integrated with community groups, linked and coordinated through phone-based apps because these people are housebound. And it's designed to work in the busy frame of general practice and chew at this problem. And so we can sequence our way through this problem. And hopefully we can use this, if data is collected, as a program for assessing and validating intervention approaches. Diagnosis is easy. Post-exertional malaise, severe fatigue, secondary symptoms, and we enter a world of a very strange disease, and as Mark says, people who think they've solved it, they haven't. It seems to affect everything, and everything seems to affect it. I think most people are familiar with that. And we also understand most of the concepts in ME/CFS can be understood. The fatigue is poor ATP production, and that's been shown and validated. We don't have enough energy being made, and there's inflammation and other things going on affecting both the brain and hormones. So if you look for something, you'll find it. What does it mean? Is that the cause or is it an effect? So if the ME/CFS has a number of different etiologies with similar presentation, then as Mark said, clumping these people together in clinical research is problematic unless you can subgroup them. And one of the things that all the doctors working in this area are trying, how do we subgroup these people? And now I've been very excited by some of the metabolomics presented here that we might have a basis for subgrouping. There was the microRNA and there was Neil McGregor's metabolomics, and you look at it and go, wow, this is maybe a way we can pre-subgroup people. At the time, we use the term clinical grouping. We're using that deliberately because there isn't official literature-based subgrouping available. Now, if it is yet a bunch of conditions to be subgrouped, then any trial will be non-conclusive. Look, we saw this beautifully at the start of this conference where they presented cytochrome 5 in mitochondria as being a problem, and it is in their research. And then we got someone from England saying, well, they didn't have any problem with cytochrome 5, they had a problem with something else in the mitochondria, right? They're both right. Can you see it? This is the problem with ME-CFS research. It's not one person. There's not a homogeneous genome. And as there are a number of metabolic problems in an individual, testing one thing in isolation doesn't work. The language I use to patients, and Mark described this beautifully with anchors. He said, you pull up all the anchors, and the last anchor they thank you for. I say to people, a truck, a semi-trailer has 18 wheels. How many wheels does it take to get it going? There's a lot of biochemical and structural and interventional things that have to be done. So while there is increasing evidence for changes in the body, we don't know whether these are primary or secondary. And there's, as Mark said, no high-level evidence, double-blind controlled trials showing what to do. So what do? Do we avoid the patient? Do we provide emotional support? Do we treat whatever symptoms we can? Do we tell them they need CBT? Do we give them graded exercise program, which is malpractice? You know, that needs to be called, it's on the Australian RACGB website, it's proven to make people ill and it hasn't been pulled down. It needs to be pulled down. So what do? Evidence-based practice has three big arms, which is best research evidence, clinical expertise and patients' values. So you've got to work in that. So the only way forward we found is to, in the clinical expertise blocks, include biochemical logic and come back to biochemical logic and to trying to work through each individual body. And we need to exclude depression. Now, I'm not going to go through this, but there's some wonderful bits which you can just sort through with CFS and depression and separating the two. And I'm not going to go through that. So what do we have? ME-CFS seems to be an umbrella term for different pathologies. It hasn't been adequately subgrouped. The research suffering from this lack of subgrouping. There's high-level evidence for symptoms and signs or marker associations and causal associations. And there's no final common pathways. They might yet be found. The human genome is not the same. Everybody's got different SNPs. And there may be more than one layer of pathology in a person. So there's more than one thing going on. And there may be pre-existing conditions that predispose a person to pathologies and limit their ability to recover. So this is a cocktail for confusion. And they create a level of complexity, and then this complexity sits in front of you in the form of a living patient with real skin who wants help. So have some compassion on the doctors. The doctors have got pressure from the government saying, shut down what you're doing, you don't fit with a keyboard, right? You've got incredible complexity with biochemistry and some very difficult people. If you've seen some people with severe CFS when their brains go off, what are they like? They're hard to handle because they're overloaded, they're in stress and they'll lash out. So they've got to manage that. They've got to try and get them better, and they're not sure what to do, and there's no evidence. They're under a lot of pressure. The next thing is, I'm getting grey, Mark's getting old, right? You've got a dog that's keeping you young. Yeah, well, not really. Doesn't do much, does it? So what are we going to do? We'll be falling off the perch in a while. No, seriously, you've got to think about this. Where's the young ones? And the young ones look at Mark and they look at me and they look at others and they go, why would I do that? So I'm speaking to the doctors of the future in this tape, please. I'm telling you there's a way forward. And we want more doctors for the future to do this. And what I'm putting out, the reason I'm putting this out, and I'm on a mission to get this out, and I'll be integrating as much as I can, is I've had a serious head injury, which has limited my capacity to work. But what has woken me up is that I can't make a dent in the CFS problem unless I multiply it. I could work 16-hour days before. I can't do that now. So I'm now dedicating my time to put together something that we can multiply that can go into general practitioners' offices that they, in the time period of general practice, can work on. When they don't know what to do, they can send it to Mark or me, but we can multiply it. I want to integrate Neil's metabolomics and others in this, and we want this to be tied with computer programs that link it back, apps on phones, and link people together in society. That's what we've been working on very hard for a number of years, and we're almost there. Now, we've said that most medicine starts with symptom complex, diagnosis, treatment. Yes, you've got that? Now, if you think about it, and don't criticise the doctors, information's doing this. Immunology information's gone out. Genetics information's gone out. Biochemistry information's gone out. There was established anatomy, physiology, histology, pathology. That was already there. And then pharmacological information's gone out, and the training on the medical courses come in. How else can you approach this unless you work on pattern recognition, which is what medical training now is pattern recognition. But in this process, pattern recognition is useless. So we have to have a targeted problem-solving approach where we layer the body. So we start, and we're going to go through these questions quickly. I don't know how much time I've got left, Heidi. Are the elements needed to run the body's biochemistry present?
Sorry, 20.
Are there heavy metal blockers? Great. Are there any nutritional vitamin cofactor deficiencies? People lose amino acids, they lose different things. Are there any manageable genetic issues? Are the precursors available for mitochondrial energy? Now, what we do with this, we've got algorithms through this and layered pathways through that. But how do you get there? You just can't start these. And these questions have to be open, and they have to accommodate new research as it becomes available. So types of clinical groupings we've looked at, and then you can't even work with those. So what we've decided to do, we've been working on the clinical presentation and onset, helps drive us into a clinical grouping by which we do an ordering of the questions in the layered targeted problem-solving approach. And having looked at Neil McGregor's presentation with his 3 groups and some of the microRNA stuff from this conference, I'm coming back to Melbourne to bang some ears and talk and think and see if we can streamline what we're doing and make it better. So we make a diagnosis, you exclude other conditions, you establish a care plan, you stabilise the patient. Now, of all the things we can do, we can stop people pushing through. When chronic fatigue patients push through, they go from ATP to ADP to AMP, then they lose the AMP as it breaks down and it passes out the urine, and then they're left in a very difficult position where they can't make energy again. So stabilising the patient and teaching them not to push through is a fundamental, and that's why the PACE program is so evil, because it makes them push through that barrier. Chronic fatigue people must not push through their energy envelope, or they have side effects. We establish recording and monitoring, and the recording and monitoring we do is graphical. It's no good seeing 6 out of 10, 5 out of 10 on a piece of paper. We want graphs. And we want graphs in which we can put lines down and we can see we've made an intervention and perhaps a month later there's been a change. You can look at a graph very fast. And in clinical grouping where we can, and then we start the layered targeted problem-solving approach. Now, I've split it into 2, so you can read it. And I'll just start going through some of the things we look at. And the idea is that this can be done by a GP, and as Mark says, you pull up anchors. So I'm trying to get it so GPs can work with biochemistry and pull up anchors and help people, because there's so many people who are ill and there's no doctors. So how are we going to do this unless we can put out a layered, targeted problem-solving approach that GPs can do in their own offices, even if they don't really understand it. And when they get stuck, they can refer it up the tree, right? So, in our multiple biochemical analysis, we measure the top 3, maybe 4, and then we come down. Now, zinc, in Australia, we find deficiencies often in zinc, not so much in iron. We find a lot of deficiencies in manganese. And years ago, I had a nurse who had chronic fatigue, and I just shot off a magnesium level, and the lab by mistake did manganese. Came back as unrecordable. I said, what the hell does manganese do? So then I started thinking, what other elements are required to make the body's biochemistry work? And any of these chronically ill people, when they have increased renal flow and flux, they lose all sorts of things, and their diets are not good and their guts are not good. Maybe they're not absorbing. So let's ask the question, is everything in the body, and no body's the same, to run the body's biochemistry? That's the first question, and we find no, it's not. So the first thing is to get all the minerals up to the right level. We find no molybdenum. We find selenium low. Selenium's critical for glutathione. Selenium also helps convert your T4 to T3. A lot of chronic fatigue people are cold and have low basal temperature. It's driven by T3. Iodine is often low. I've been stunned. I would say 25% of the people I measure are World Health iodine deficient. It's just crazy. Boron is required to move phosphate. Phosphate's required an ATP, and we can go on. So the first thing is, get everything in the body so the biochemistry can work. We haven't even looked at blocking biochemistry problems, but if it hasn't got it there, it can't use it. Are there heavy metal blockers present? That's the next question. I'm not talking about hair. In Australia, we have a cultural problem. If you do hair analysis, you're deemed to be a witch. If you look at urine, you're deemed to be a doctor. Okay, so I use urine. Stay culturally appropriate, don't start fights with... So we use DMSA provocation, and guess what we find in kids? We find cadmium. A lot of kids have cadmium. Where the hell is cadmium coming from? CSIRO, I got involved with talking with them, comes from superphosphate. Cadmium's in superphosphate, lands in the plants. Australia's topsoils are deficient in zinc, manganese and molybdenum. Because we're deficient in zinc in our topsoil, cadmium, which is underneath zinc on the periodic table, can work in that enzymatic structure in the plant, doesn't do damage to the plant. When it lands in us, it does damage. You absorb it, particularly if you're low zinc. Most Australians are low zinc. The reference ranges for zinc in Australia are different to the reference ranges in America, because the reference ranges are based on the normal distribution of what comes into the lab. They're not based on absolutes of what's good for a body. So you have to understand that the reference ranges in laboratories are based on what's coming through that laboratory. So just check out the different reference ranges between America and Australia. We're low in zinc. The lowness in zinc in the Australian population means cadmium can be absorbed. It poisons people. So we find mostly cadmium in kids, then some lead, mercury. I've never found thallium, and I find a lot of copper. When I got a hold of the copper, I didn't know what to do. I met somebody from the EPA in South Australia, and at that stage they're conducting an investigation because they'd found copper in wastewater at Bolivar at the central fecal processing place, and they thought, oh, someone's dumping copper into the wastewater. As they went up the pipework and split, all of a sudden they discover it's coming from houses. Australians use copper for their water pipes. If you've got highly treated water like Adelaide, which has got a lot of particulate things in, you get ionic copper coming in. Ionic copper damages the body. Copper is required essentially for a lot of things. It's required on your electron transport chain, but as copper gets up, it will block the electron transport chain. The enzyme we've got in our body to break down vitamin C is copper-based. It's vitamin C oxidase. You'll chew up your vitamin C when your copper gets up. We don't have a gene to make vitamin C in our genome. It's broken. You've got to go back down the phylogeny to find out where it's not broken. So all of these things work, and as Mark said, you pull up the anchors one at a time. And then we start looking at SNPs. What can we find? We've got questions with the SNPs. Which ones have a clinical effect, because a lot don't? Which one is associated with specific biochemistry and pathways that we can do something about? And what can we do about it? And We use a lot of this pathway. I've stolen this from a website last night because I couldn't find one. But you're starting with the urea cycle, the tetrahydrobiopterin cycle, the MTHFR cycle. We play a lot with that to get that right. And it's not as simple as you think, because these things can run backwards and forwards, so biochemical pathways can go both ways. And I've particularly found sometimes if I give methylated B12 to people, occasional people will have side effects, and I've discovered that's from the VDR gene and the COMT gene if they're also down. So you have to work your way through it and do what you can for the person. The other thing with the manageable genetic issues is the celiac HLA. Now, a lot of people in Australia are from Europe, from Northern Europe. The celiac HLA gene is called the celiac HLA gene. It doesn't code for celiac disease. It codes for presenting cups on cells. The presenting cups on cells which your immune system check. When you eat gluten, the gliadin component of the gluten looks like an infection to your immune system. So if I find the celiac HLA gene, what this is this is a gene for immune confusion with gluten. It will also cause celiac disease if you happen to have a trigger in your gut, and it will trigger celiac disease, but it can maintain autoimmune diseases and it can maintain immune confusion, and that's what you don't want with these people. So I do this gene test, and if it's there, I say you're getting off anything with those proline residues of the gliadin complex. It's a proline at a central amino acid. And then we ask questions about mitochondria. Now, I need to say that with the heavy metals which we've gone through, one of the treatments for heavy metals, because when you treat heavy metals, you first treat the body, then you treat the brain. To treat the brain, you have to use one of the carriers, R-alpha lipoic acid. So you notice I put heavy metals before mitochondrium, because one of the treatments for mitochondrial things is to replace R-alpha lipoic acid. If you replace R-alpha lipoic acid in a person with high cadmium, you'll shuttle cadmium into the brain. There's none of the other carriers cross the blood-brain barrier but R-alpha lipoic. So I put the heavy metal sorting out before I start hammering the mitochondria. ATP is made from AMP. AMP is made from D-ribose and vitamin B3. So that central line there, when people crash and are lying bedbound, you load them with D-ribose, load them with B3, and that will reduce, won't fix, it will reduce their bedboundness. So there's supplements you can take. Now, the electron transport chain, which we're focusing on, is the most wonderful piece of technology. If you ever get a time to look at it, what it's doing, it's taking electron energy, which is quantum, it's taking the energy in electron and reducing it in quantal states. It's using those quantal state reduction to pump and move hydrogen into a pressure vessel. And then it's using the pressure vessel to drive a water wheel. And then it's using the water wheel to compress things together for a chemical bond. If that's not flippin' amazing, like if you ever get a chance to just pause and look at what we're playing with, it's absolutely glorious. The electron transport chain just does my head in sometimes with the nanomachinery, but it's typical of the whole body. So then we ask questions about the gut. Now, you would have heard everybody working in this area is of the opinion that the gut drives health and that the immune system revolves around the gut and the brain revolves around the gut, and we all agree on that. And there's a lot of things you have to test for. The testing we've got with fecal material is two sorts. There's the bioscreen, which is microbiological based, but that's measuring what's alive, and there's also DNA-based biome testing. The thing missing in this process is our understanding of phages and how phages sweep up and down through the gut. As phages sweep up and down through the gut, they kill bacteria. So we've yet to sort that out. Those phages are meant to be there because they lyse bacteria and release the goodies for us. We ask questions about, has a person been exposed to a biological toxin? People who've been in blue-green algae water, people who've been in mould areas, and you can use functional acuity contrast testing to see if they can see grey on white. That's now available online. And you can use cholesterol or lipid binding agents to move that. That's courtesy of the CDC in America when they had the Pfisteria outbreak in America. They couldn't, the question is, how do you remove a lipid-soluble neurotoxin from the body. Or they use the enterohepatic circulation of the liver as it squirts things out into the bowel and reabsorbs it. Well, it squirts it out into the bowel, pick it up from the bile, and don't let it re-enter. And that's brilliant simplicity. And then we ask questions about infection. Now, we consider these together. And this is a simplified format of what we use, but we try and look at, is there an infection? Is there an infection with an underactive immune infection, or is there no infection and it continuing? Now, I'm sort of trained in ID, infectious diseases, so I have an infectious bent, but the fascinating thing about this disease is that people can't find infections. And that's what you look at the work from Ron Davis and what they're layering out. While you hold that together, you have to also hold the clinical truth together that we've had people die from people using steroids. Now, corticosteroids will reduce the inflammatory response of cytokine overdrive. And you can be on low, moderate doses of corticosteroids for years without getting ill. We've had a couple of kids who've been ill, and some well-meaning GPs put them on corticosteroids. Their immune system down-regulated, they felt well, and after 6-9 months they died because they did have an infection, and the infection could run rampant. Do you understand? This is why this is such a difficult thing. Now, they must be the oddities because of the work that's happening, which is showing no infection that's typical for this thing, but you still have to be aware there are infections running. And on the Borrelia debate, there's a Borrelia debate for those who are not from Australia, but there's a Borrelia debate occurring. One of the things we have to consider is Australia is phylogenetically separate from the rest of the world. In the last ice age, the water did not drop on Wallace's line, which is the line that runs up through Indonesia to the Philippines. On one side of that, there is one set of animals and plants, and on the other side, there is us. Animals have arisen on this side which are different to the other side. It would not surprise me if the Borrelia we have in Australia is different to the Borrelia that's on the rest of the world. So I think that there's more work to be done on that. One of the things I do find, and you find this in autoimmune diseases, is the calcitriol question. And we find a variance between 25D3 and 125D3. Now, vitamin D, we were taught, was about bones. We're now realising it's a pluripotent hormone. It's the core of the immune system. And on the surface of white blood cells, DAMPs and PAMPs, which are danger-associated molecular patterns and pathogen-associated molecular patterns, when they're both hit together, the body will convert 25D3 to 125D3 or calcitriol, which then hits the receptor on the nucleus, which then puts out our own internal antibiotics. Now, there is no resistance to our own internal antibiotics. So germs have worked out how to stop that occurring. So in the evolutionary pathway, AIDS does a total block of that pathway. Other things do a partial block of it. What I find a lot of my patients, I find this raised. So I don't know if Ron, if you can look at calcitriol and see if it comes up with anything on your guys, but I'm asking myself the question, are there pathogens which are also blocking the vitamin D receptor that we don't know about? We don't know how it's working, or what is this mechanism? Because it's a marker I regularly find. We've heard in the conference about the serologies. Serology goes up and down as your immune system goes up and down. You want PCR or DNA probes, cytokines of profile. So you check all these things. Another question, are there hormonal deficiencies? And I often find low DHEA in my patients. If I find low DHEA, I start running around the clock looking. And when we could do it, we can't measure it in Australia at the moment, we could do pregnenolone. And in a number of patients, we found low pregnenolones. Now, that's fascinating because pregnenolone is manufactured on the surface of the mitochondria. And we already know that we've probably got a mitochondrial problem. So there's layers in this. So we go through these questions and you promise the patient nothing. You just promise the patient that you'll work with them, give them empathy and layer it and progress it. We want to keep the questions open and incorporate new research, and we want to be able to translate this back into general practice so a general practitioner with a partial interest can proceed and we can multiply the work. Okay, so there's some of the testings you do, and that's the end. Thank you.